Transplants don't last forever.
This is a patient who had a full penetrating keratoplasty, a full thickness transplant, but the endothelium, the back layer of that transplant tissue, started to fail. And now the patient's going to undergo a procedure to do an endothelial transplant to replace that tissue.
Endothelial transplants require less recovery. There's less sutures used, less dangerous because the opening that's created, even though it's large, about 6 millimeters, is not as large as taking the whole cornea off. For these patients, I have decided to go with DSAEK if it's a more complex case, and the openings allow 1 access, and 2, you'll see a little anterior chamber maintainer which injects fluid while I'm working.
And you say you prefer to go to with DSAEK versus a DMEK, for example, correct?
Correct. This is now a crescent blade used to create a scleral tunnel. Scleral tunnel starts in the white part of the eye, thus avoiding the clear layer, which would be closer to the cornea. So if you do a clear corneal incision closer to the limbus, it doesn't seal as well, and I'm also much closer to the corneal transplant. The constriction is caused by a myostat, which is a medication that acts on the pupil sphincter and makes it contract. This is a 25-gauge needle on infusion that is used to perform little iridotomies that allows or prevents capsular or pupillary block when the air bubble is placed.
And iridotomies are just holes in the iris. That's going to allow the fluid to pass from behind the iris to in front of the iris.
Correct.
And allow for that fluid exchange to occur normally.
Yes, as long as the air bubble is in place. These are so small that no patient has complained of any dysphotopsias or glare from this yet. The transplant I prepare by passing a suture through that one layer. This is a sandwich transplant. It comes marked and cut by the donor network, and it is a tissue where the one layer is less than 100 microns thick, and then the cap, which was basically cut off, can then be removed so that I only have a little bit of stroma with the endothelium.
And that's the goal of the DSAEK. It's going to have endothelium, descemet membrane, which is the basement membrane of endothelium, and then just a small portion. You say about 100 microns?
Less than 100 microns.
Less
70
than 100
microns is what I usually go for. The thinner, the faster the visual recovery. It is more difficult to handle the thinner it is, but I think it's worth it with the recovery. And here the descemet membrane of the patient, of the cornea, is removed. This transplant that has this, again, this is the sandwich that's still placed on these busin glide, and then the cap is separated from that transplant tissue. The little suture serves as a guide and will lead the tissue into the eye. The reason for all this manipulation outside the eye is because I prefer this to manipulating inside the eye.
Yeah, that would probably not be preferable to do all of this inside of the anterior chamber. So that's that leading suture that we're going to see, and that's going to be the first part to pass through.
And you see a little S stamp that signifies the correct orientation. That's the cap that's removed, and you see how much thinner that tissue is as it gets pulled forward into the tip of the busin glide. The busin glide, the suture is then passed in front of the glide while the anterior chamber is just filled with saline, so it's not the viscoelastic that you see during cataract surgery. The saline is continuously replaced by that maintainer. You can see how it gushes out, and as soon as the suture is in, the anterior chamber is stable again and now maintains its space and pressure. Low pressure in the eye can lead to problems such as choroidal hemorrhages, choroidal effusions, and also the collapse of the anterior chamber can lead to the tissue being compromised by being collapsed or compressed between the cornea and the iris.
And you mentioned that it's because this patient had a prior corneal graft that you chose to insert this through the sclera. Are there other reasons that you would use a scleral tunnel, or is it really just because of the PKP?
Well, any time when I want a more stable wound, I use the sclera. So patients with RK, I will do a scleral tunnel, and you can see that opening in there, and you saw how the anterior chamber didn't really collapse. It stayed nice and stable, and the tissue is already unfolded by being pulled in. This little air bubble maintains the graft on top and pushed against the cornea, and that allows me to stabilize things, close the main incision, and get everything else ready. And you saw how that tissue now kind of moved over to the side. Initially it was centered and then kind of slipped over a little bit.
Is there any need, because the bubble is in there, for a patient to maintain a certain head position after the surgery?
Ideally, yes. It kind of pushes things forward so the air bubble will go up. And so I want the front part of the eye where the air bubble goes. Most of the time for DSAEK, I think after 1 day, they should be positioned well. These sutures are not absolutely necessary to close the wound because the wound is self-sealing. The sutures more serve to kind of keep things in place should the patient push on it, so they're more safety rather than actually necessary to keep the suture in, the wound closed and the eye inflated.
And just a little manipulation to get the graft nice and flattened out, a little more air added, and finally a little stitch placed in the cornea as well. Is that going through the graft?
That's going through the graft, and this is one extra safety suture because, again, in these patients, I also tend to do this kind of procedure in the patient who can't position as well, let's say an older patient. And so I want to make sure that everything stays exactly where I want it to be so it doesn't dislocate, doesn't decenter, and that safety suture will do the trick and remove the other suture. You probably noticed it was still there when I placed the one, and I only removed the leading suture once this suture is secure, everything is centered, the suture that I pulled the graft in with is safe and secure and can now be removed. So patients who had vitrectomies, where the anterior chamber isn't stable, who are aphakic, this is still very safe because the likelihood of the graft dislocating into the vitreous without me being able to save it is almost non-existent.
So hopefully the whole goal behind this is to replace that endothelium and make sure that that other rest of the cornea can maintain its proper function and pump out the fluid necessary.
And here you see the S stamp signifying the appropriate orientation of the endothelium.